Radhe Radhe, a very warm welcome to our Friday Health Webinar Series. Today we have Dr. Sunil Thummala presenting his health webinar on a very important and a most sought out topic of early identification of neurological emergencies. And thank you so much, Dr. Sunilji. I know you took time off from your yoga teacher's training, and Deviji has given you permission. So thank you for that. And it will really benefit and educate our viewers. And I would also like to thank Dr. Khandalwalji for being, organizing a health webinar. And let me introduce Dr. Sunil Thummala. Dr. Sunil Thummala is a board-certified neurologist. He lives in Frisco. He practices neurology with offices in Paris, Texas, and Frisco, Texas. He finished his medical school in Bharat and then finished his neurology residency in Vermont. He also holds an MBA degree in health sector management. His interests are yoga, Vedanta, consciousness, and of course, neuroscience. He lives with his wife and son, Tejas. Welcome, Dr. Sunil Thummala.
Namaste to everyone. So before we start this topic today, let me just start with one Shanti mantra. Om Sarve Bhavantu Sukhinaha, Sarve Santu Niramaya, Sarve Bhadrani Pashyantu, Ma Kashit Dukkha Bhag Bhavit. Om Shanti, Shanti, Shanti. I will let the audience explore the meaning of this if you have not yet explored it. And I'll also want to express my gratitude to Swami Vivekananda. Today is his 127th anniversary. The day on the day on which he came to US and gave his famous speech in Chicago. And he addressed the nation with his first words, sisters and brothers of America, which essentially changed the image of Bharat in the Western Hemisphere. And obviously all of us should be feeling proud of it. Also today, on the flip side, we are remembering the victims of 9/11 attack on the US soil. So at least we'll observe 1 minute of silence in honor of the victims and also our first responders who suffered and still suffering from some of the devastation caused on that day. So we'll just observe 1 minute of silence before we proceed. So we can get back into our presentation. So today's topic is early identification of neurological emergencies. We call time is brain. So essentially every second counts if there is a neurological emergency. Brain does not regenerate. So we want to preserve as much as we can if there is any injury to the brain. And that's why early identification of neurological emergency is very important. Binaji, we can go to slide 3. So as a disclaimer, again, I do not have any conflict of interest to disclose today. This is a community educational event organized by JKYog. And again, our goal is to educate the community members all over the world, in fact, on the neurological emergencies. Our goal is to benefit you. This is not intended to replace any professional medical advice. So if you have any specific questions related to your individual health related question, please, you should consult your doctor as this will give you some forum to start where to explore. Next. Neurological emergencies can present with varieties of symptoms. The symptoms can range from the top of the head to the tip of the toe. So essentially, you can label anything as neurological emergency. So I'm going to present the most common ones that needs to be identified early so that you can seek medical attention quickly enough so that the outcomes are better. So the symptoms of neurological emergencies can be headache, double vision, any change in your vision, including loss of vision, droopiness of face, slurring of speech, any difficulty swallowing, which are acute onset, any acute onset weakness, acute onset numbness, acute onset imbalance or dizzy sensation. A lot of times people don't go to neurologist, especially if they have dizziness, but it is, I will explain further why it is important. Sudden loss of sphincter control, bladder or bowel sphincter control, acute radiating pain into your arms or legs. Of course, seizures, which often in Bharat they referred to as fits. Severe neck pain, that's again rather acute in onset. Fever, rash, confusion, when they happen together, that indicates something. Sudden loss of consciousness or sudden confusion or altered mental status, that is rather acute in onset. So this is essentially a glimpse of symptoms of neurological emergencies. Next, Binaj. So, and these are some of the pathologies that can cause those symptoms. Obviously, I will go over some of these pathologies and how these can relate to the symptoms. Ischemic stroke, that means a clot-based stroke. Intracranial hemorrhage or epidural hemorrhage. These are essentially bleeds that happen in the brain and around the spinal cord. Drug-drug interactions, very common nowadays. People are taking too many medications, and one doctor prescribes one medication, another doctor prescribes another medication, and now, okay, these two medications interact, causing complications. Overdosing. People accidentally or consciously take too much of these medications can cause either seizures or loss of consciousness or even frank death. Meningitis, encephalitis. Essentially, these are infections of brain and spinal cord. Abscess, which is the accumulation of infection and pus around the brain and spinal cord. Guillain-Barré syndrome, which is sometimes seen as a complication of vaccine, and sometimes it can be seen after a diarrhea or a simple infection like respiratory illness. Acute exacerbation of chronic conditions. Sometimes you may be having a chronic condition like MS or CIDP, which are very chronic, but sometimes they can become suddenly worse and it can be life-threatening. So you need to identify that. Compressive neuropathies, especially crush injuries involved in an accident, and it can compress the nerve. And if you don't intervene on time, then the nerve can die and it is irreversible. So example is a compartment syndrome that happens after a prolonged laying on the floor without moving, especially if people fall in bathrooms, they can't move, elderly, in the night they fall and they can't move. Somebody sees them in the morning and they have significant muscle injury causing compartment syndrome and nerve damage. Acute disc herniation, very common in technology people, and because of our lifestyles, too much weight on the spine causing disc herniations. Vertebral body collapse. Osteoporosis can lead to vertebral body collapse. Any trauma can cause various fractures and rupture of meninges around the brain and spinal cord, causing spinal fluid leak. And status epilepticus, a significant emergency. Rhabdomyolysis means which essentially an injury to the muscle, which can happen after a seizure or after a loss of consciousness. And cardiac arrest. I specifically put here cardiac arrest because the consequence of cardiac arrest is not per se the heart. It is the victim is the brain. So that's why the CPR or basic life support, compressions of the chest has to be done very quickly to protect the brain from the injury when there's a cardiac arrest. So previously we used to do something called a CPR. Nowadays we call it as a compression first, not like airway first. We are doing compressions first because air is already in the lungs. So at least we want to pump that oxygen to the brain. So start compressing at least for 1 minute if somebody loses consciousness and no pulse is identified. And that protects the brain from any hypoxic brain injury. Next. So first, headache. Headache is a very common symptom. A lot of people have headaches. A lot of people think they are benign. Varieties of headaches. And there are headaches that fall into primary headache categories and secondary headache categories. In general, in medical science, we do not call something as primary until we have excluded secondary causes. Often I see that patient is told that they have migraines. And when I ask them, do you have any scans done or any laboratory work done? They say, no, I was told I have migraines. But the question is how? Essentially, anything can mimic migraine. Even a secondary tumor in the brain can cause migraine-like headaches. But if you keep treating them as migraines, you will miss the time to treat. So it is very important that we look for secondary causes. And sometimes the secondary causes are life-threatening, but you may be given a warning when there is a bleeding in the brain, especially if there is an aneurysm in the brain. Often aneurysms rupture initially, very small rupture. It can lead to bleed, and that bleed can lead to a sudden onset of thunderclap headache. People describe it as worst headache of life. It's a thunderclap like a lightning strike on the head, and it may go away after a day or two. And that can be sometimes a sentinel bleed, a warning bleed. If you don't intervene at that time, you miss the opportunity, and the patient may have massive rupture of aneurysm and may not even reach hospital to survive. So anytime patient has acute onset of headache, that's a red flag. It needs to be investigated. And do not assume even if it goes away in a day or two. And just medicating if there is acute onset of headache is going to cause more disasters. Especially people take like anti-inflammatories, including aspirin, which can thin the blood and make the condition even worse. So, important thing, if there is acute onset of headache, which is like thunderclap like headache, important thing is to go to ER. Otherwise, at least inform your primary care. If the headache has improved, as soon as possible, inform your primary care so that a necessary testing can be done. And sometimes the blood pressure can shoot up like into 200s, and it may cause a rupture of blood vessels, causing intracerebral bleeds. And again, the only symptom can be severe headache. So very important. And sometimes it's not even rupture. It is just a leakage of fluid called edema, cerebral edema. And the only symptom can be headache. So acute onset of headache, do not neglect. Infection, meningitis, especially. Early symptom, headache. And meningitis can be rapidly progressive and life-threatening within matter of hours. So do not neglect it. And we can go to next slide, Binaj. We can go to the next slide. Yeah, so next slide. We can go. Okay, so that is about the intracranial aneurysm. As you can see, there are varieties of aneurysm. Aneurysm just means a bulge or a outpouching, like a grape-like outpouching in the blood vessel wall. It can be, there are varieties of aneurysms, but these are the commonest ones. And as you can see, these aneurysms have a very weak wall. It is like a pipe that is very weak at one place. So with the pressure in the blood vessel, it will rupture. And often you may get a warning rupture, very small rupture, 24, 48 hours before a massive rupture. So that's when the best time to treat and catch it and treat it. If we neglect it, then it may lead to massive rupture. And a lot of times, patients who have aneurysmal ruptures may not reach the hospital, and they are essentially herniate and die en route. So very important to diagnose early. Next. So this is a epidural bleed. Here the bleed happened in between dura and the skull. So your brain is surrounded by three membranes, which is called pia mater, arachnoid mater, and dura mater. Dura mater is a very thick membrane, and it has two sheaths. One sheath lines brain, and another sheath is lining the skull. If the bleed happens above the epidura, it is called epidural. and often it is arterial bleed. Arteries have blood pressure. So because of that pressure, blood will gush out, and often they form a crescent shape because the dura is essentially attaching to the skull, and it cannot go any further, so it forms a crescent. But since the blood vessels, particularly your arteries, have arterial pressure, which is very high, the blood will come out and then it will compress the brain tissue, pushing it to one side. And often this is seen with skull fractures. People go for skiing or fell in the bathroom, particularly there is a skull fracture above the ear called temporal fractures, and it may rupture the artery there and bleeds. Interesting thing here is it will bleed, you may experience severe headache, and after a while the headache goes away, and that's called honeymoon phase. People think things have settled and everything is normal. Only is that is a honeymoon phase, means things are building up, and by the time patients experience sudden herniation, it is too late. And I think there was one movie actor who died in this very similar fashion. She was skiing and then fell, had a bleed, and then went into this honeymoon phase. And then, she died. Looks like she was not diagnosed early on because she did not go on time. So it's very important, if there is any injury and headache, a bleed has to be ruled out, particularly epidural bleeds, because they can be life-threatening. And once herniation happens, the chances of survival goes very slim. Herniation has to be treated with the evacuation of the clot. And majority of the places throughout the world doesn't have sophisticated surgeons and big universities to take care by major neurosurgeries. So, but if you can identify it very early, at least you can be transferred to a right place. So very important, if you have a injury with a headache, at least get checked by a CAT scan at the nearest hospital. So I purposefully put this slide just to give a sense of retinal detachment. Although it is not a neurological emergency, it is ophthalmological emergency. It can cause varieties of visual manifestation looking like stroke, but this is also an emergency. So if you have any acute change in vision, especially with eye pain, that could be a retinal detachment. So, and it can be easily treated by an ophthalmologist if you can go to the hospital and ophthalmologist is involved on time. Next. And this is a neurological syndrome where patients often complain of curtain-like symptoms. They were doing fine, and all of a sudden they see that vision is going down as if a curtain is coming in front of their eyes. And this is because a clot is obstructing central retinal artery, a blood vessel supplying the optic nerve. And when this blood vessel is occluded, the blood is dropping off from top to bottom. And so you see this curtain coming, vision is going away. And when you look into the eye with the fundoscope, that's how the picture, your fundus will look like, very pale. And you see a bright cherry red spot. And that indicates the blood flow to the retina has significantly reduced. And the circular place where these blood vessels are coming from, which is called fundus, looks very pale. So a pale fundus, cherry red spot, and your vision going down is a stroke of retina. So often it is seen in patients who have atrial fibrillation or some clot coming from the heart going into the central retinal artery of the eye, causing this one-sided curtain-like vision loss. And this can, if not treated within appropriate time frame, you can become blind. So this is a stroke. So essentially it is a stroke of your retina. Next. So this is a simple picture of your cranial nerves. So we have 12 cranial nerves. Most of these cranial nerves come from the brainstem, which is essentially a highway between your brain and your spine. And that spine connects to your body. So your brain, being the processing center and the controlling center, connects to your body through your brainstem and through your spinal cord. So you have 12 cranial nerves on each side. The first cranial nerve is your olfactory nerve, which is a smell nerve. Often we are seeing in this COVID-19 outbreak, there are cases where patients are complaining that they are unable to smell. And it is reported that one of the only symptom patients with COVID-19 are having is a loss of sense of smell. And it may be because COVID-19 is doing direct injury to the olfactory bulb, which is located in your in the upper part of your nose. And if you have any accident, that olfactory bulb can be detached from your olfactory nerve, and you may lose sense of smell. And again, so loss of sense of smell, if it is acute, can indicate that there is an injury to the olfactory nerve, which is your smell nerve. Next. This is a sixth cranial nerve paralysis. As you can see here, this person is trying to look to the right. So this person is looking at the right. The left eye is going towards the center. It is able to go. The right eye, which is supposed to go towards the right, is still in the center. It is not moving out. It is just staying at the center. It is because the sixth cranial nerve is paralyzed. That nerve is supposed to pull it to the right side. Since it is not able to activate your muscle, lateral rectus muscle, the eye is not moving. And this is one of the symptoms of brainstem stroke. It can be seen in other cases as well. But if you have double vision, this person most likely is experiencing double vision. When looking at the right, the person is seeing two. When looking at the left, the person sees only one. So seeing double when looking at the right, seeing one single object when looking at the left. And that is a right sixth cranial nerve palsy, paralysis. So it is a sign of a brainstem stroke. Sometimes even diabetic patients can experience it when there is a stroke of the nerve itself. And this is often seen. Patient goes to hospital with a double vision. They do some CAT scan or MRI. They say you don't have stroke. And patient goes to ophthalmologist. Ophthalmologist tells you have sixth nerve paralysis. This is not eye problem. This is your brain problem, neurological problem. And MRI is negative. And they say, okay, I don't have stroke because MRI is negative. No, MRI does not rule out stroke in every case. So this is a stroke of the sixth cranial nerve, the nerve stroke. And the resolution of MRI is not that high enough to see the stroke of the nerve itself. So that's why we need to have index of suspicion. So in a neurology, exam triumphs testing. So we don't go by testing. Testing is only an ancillary tool. It is an exam that matters. Next. So this is a facial weakness. On the left side of the screen is a Bell's palsy, and on the right side is a stroke. And often I see patients who are told as Bell's palsy in almost every case. And strokes are often missed in the cases like the right side we are representing here. When you look at the left side, the face is drooping. The right eye is wide enough. The palpebral fissure, the eyelids are wide compared to the left eye on the picture on the right side. So that's a Bell's palsy. Whereas if you look at the image on the right side, all the way to the right side, the face is drooping on the left side, but the eyelid is also drooping, as you can see. And that's a stroke. And whereas the left one is a Bell's palsy. Bell's palsy is benign. It has very good prognosis. You can just give steroids and things will most likely return to normal, like what is showing there in the picture. Whereas on the right side, you have to admit the patient to hospital because that patient may be at risk for another massive stroke. So often, if you look at the left side of the patient, this is on the right side of the screen, if you label them as Bell's palsy, which I have seen, and they were sent home, and only thing is, the patient says, I also feel numb in my face. Bell's palsy does not cause numbness. That's a red flag. So they call our office saying, hey, I was referred to your office. And what are the symptoms? My face is drooping. I'm feeling numb on the face. Red flag. If it's just a drooping, I think people might miss it. But if once they say they are having a droopiness plus numbness, or if they have double vision, or if they have slurring of speech, any of those symptoms, that's a stroke. And you have 4.5 hours window to treat an acute stroke with medication called IV-TPA. So stroke is a neurological emergency. It is a time-sensitive matter. Every minute counts if you have a stroke. And it's okay to wait for 5 minutes if you have symptoms, but if you don't improve in 5 minutes, you have an acute symptom, call 911. Next. So that's a clot that is obstructing a blood vessel. So blood vessels are essentially supplying the brain. Brain does not have a reserve capacity of a blood flow. It doesn't have too much of glycogen reserve. It doesn't have a lipid reserve. So essentially, it is dependent on constant supply of oxygen and glucose. Your heart can depend on some fatty acids. Your liver can survive. Spleen can survive. Your muscles can survive. Bones can survive. Brain needs constant supply of oxygen and glucose. So brain essentially shuts down within seconds when there is a blockage. So every second you wait, millions of brain cells are starting to die. And the damage starts at the core where the blockage is, and it starts to spread outwards. So if you can go to hospital as soon as possible and open this clot, whether using a IV medication or by using catheters, nowadays in big hospitals, they have catheters. If clot is big enough and occluding a major blood vessel, they use catheters as well to open the blood vessel. And once you open the blood vessel, you can salvage as much of the brain tissue as you can. But if you leave it alone, after 4.5 hours or so, damage is significant. And stroke is the #1 cause of disability worldwide. And most of these patients will end up in wheelchair or prolonged rehab. And every stroke reduces your life expectancy by approximately around 4 years. And every minute you wait when there is a blockage, you are losing millions of neurons permanently and billions of connections, the synaptic connections between neurons every minute. And these are irreversibly lost. So it's very important to open these blockages as soon as possible. So time counts. So if you have acute neurological symptom concerning for stroke, if it is lasting more than 5 minutes, you should certainly call 911 or ask someone to take to ER. So this is one of the acronym you can use to know the symptoms of the stroke. There are many acronyms. Simple thing is FAST. If your face is drooping, or if you're weak on one side of the body, arm or leg, or if your speech is slurred, you should call 911. If there is audience outside the United States, whatever your local emergency system is, you should activate it or ask someone to take you to ER if they can take you. Most of the times, if you live a little bit far away, that may not be a good idea because you may be stuck in traffic. And if you go by ambulance or by air ambulance, maybe better, you can get the treatment quickly enough. But if you drive yourself, you may end up in accidents or you may end up in traffic jams and you may lose precious time. So it's very important you activate the 911 system. So all the 911 systems most of the hospitals have what we call acute stroke protocols. So they activate the local hospitals and the network of hospitals, and they will make sure the CAT scanner is ready, a neurologist is on standby, and the medication is available or not. If you are close to a stroke certified hospital, they will take you there and bypass a non-stroke certified hospital. But if you go without knowing it, you may not know whether the hospital is stroke certified or not. So that's why it's better to call 911 who has an idea which is stroke certified, which is not. So very important, time is brain. Next. So dizziness. This is another symptom often neglected, and these patients end up after a stroke has already happened. And there is nothing we can do if you come too late. So patients develop acute onset of dizziness and they're spinning, they are throwing up, they can't walk properly. And sometimes they have hearing loss. They stay at home, hydrate themselves, blame on something else, like, oh, I might have not slept well. I may have some ear infection. They end up going to ENT office, doctor's office, primary care's office. They were told, you have some ear infection, get some antibiotics. And then antibiotics doesn't heal the symptoms, and then they end up in neurology office. These patients could have cerebral stroke at the worst. They may have stroke of the 8th cranial nerve, or they may have worse cerebellar stroke. Cerebellar strokes are fatal. So that's why acute onset of dizziness, especially with nausea and inability to walk, is a neurological emergency indicative of a posterior circulation or back of the brain or brainstem stroke, which generally carries a very bad prognosis. So that's why identifying this type of strokes is very important so that early intervention can be done. Next. So we are going down the spine. So as you already know, there are 12 thoracic vertebra, 7 cervical vertebra, and you have 5 lumbar vertebra and 5 sacral vertebra, which are fused, and then coccyx, which is fused. So your spinal cord runs in the center. So your spinal cord is extension of your brainstem. So you have brain on the top, then you have brainstem, and then the brainstem is running down as a spinal cord in the center. And your spinal cord is just a fiber optic cable, just assume like that. It's a bundle of nerve fibers. There is not much processing going on. It is just an information relay center. It's a highway. So information going up, information going down. So at every level, a nerve is coming, nerve root is coming. So essentially it is like your spinal cord is like a fuse box, and from where wires are emitting out. And they are going to your fan, they are going to your eyes or light or everywhere. So whenever there is a damage to your fuse box, then you may lose your power supply in your home, in your one of the room. Same way, if your spinal cord gets damaged at any level, then whatever the nerve roots that are supposed to be supplied and whatever the organs that are supplied by those nerve roots will stop functioning. And everything beneath that level may also suffer depending on the extent of the spinal cord injury. Of all the spinal cord injuries, these two in the lumbar spine, particularly in the lumbar spine, are important. One is an emergency, one is not an emergency. On the left side, you see conus medullaris syndrome. Conus means like a bulge and medulla is a lowermost portion of your lumbar spine. The lumbar spine generally ends at your lower thoracic level. So your thoracic vertebra and spine does not go like in a one-on-one. So your spinal cord ends at around T12, L1. So there is no spinal cord at L4, L5 or in your sacrum. It's only nerve roots there. So that blue bulge that we are seeing is a lumbar enlargement. If there's a damage there, that's called conus medullaris syndrome. Often it can happen from a stroke or from an abscess or from a trauma or from a disc bulge. Disc bulge can be simple, like you fell in a bathroom and then suddenly the disc bulged and compressed that part. And immediately you can't experience any sensations beneath that level. So your legs may get paralyzed, your reflexes may change, and you may have a difficulty voiding. Your bladder may feel full, or you may have incontinence. So you'll experience sphincteric changes, and you become numb in the perineum. And then it's not much pain. So, in fact, pain is actually a good sign. If you have pain, it localizes, and the loss of pain here is bad. In conus medullaris syndrome, the pain is very little, but all other things, cannot walk, cannot sense beneath the level of lumbar area. That's an emergency. It has to be treated acutely. On the right side is cauda equina syndrome, which is the compression of the nerve roots, which are just beneath that bulge. So all this cauda equina means horse. It's like a horse tail. So these are like small hairs, filaments of nerves like a horse tail. If those are compressed, you get cauda equina. And often this is not an emergency, but certainly it will progress. So it has to be treated, but often it's an outpatient surgical management rather than emergency management. Often cauda equina causes severe pain. It's a radiating pain like sciatica, where you have disc bulge compressing the cauda equina or a nerve root. The pain shoots down your leg, but you are able to walk and you still have some sensations. A neurologist can do exam and differentiate between these two. And then they will order MRI to identify where is the problem. So it's very important if you have sudden onset of numbness or weakness or loss of sphincter control, your bladder sphincter or urinary sphincter, it is a surgical emergency. You need to go to ER right away. Next. So this is a small cartoon showing acute disc herniation, looking from one of the sides. So you can see the left side represents the back of the spine, the right side represents the front of the spine, and you have vertebral bones. And between the bones, you have discs. It is like almost like you have brick and a grout. Only difference is the grout is here not a solid concrete. It is just a jello held by a rim of leather-like substance. So you have that jello-like substance, which is nothing but disc, that gives like some shock-absorbing properties to your spine. Whenever you move, jump, you don't want spinal cord to be strained because of the forces. So that discs between those vertebral bones gives that shock-absorbing ability. But if you are sitting for a long time, or if you have any trauma, then the disc cannot hold the gel any longer, and it starts to ooze out. I would probably use the simple word ooze out. It is called herniation. And when it herniates, it may start pushing on the spinal cord. The spinal cord, as you see, is running in the center, and it pushes the spinal cord. And then you can experience loss of function at the same level, and beneath the level. You may experience pain at that level, and you may experience loss of function, difficulty walking, difficulty using your arms and legs. And worse, if this disc herniation is very high in your neck, you may experience paralysis of your diaphragm also. You can't breathe, you may even die. So that's why an acute disc herniation compressing the nerve roots is an emergency, especially if you have an acute loss of function. If it is just a pain, generally it is not an emergency. But if you lost a function, sphincter function or strength, loss of sensations, difficulty breathing, that's an emergency. And so in that case, you have to right away go to ER. If it is purely pain, it can be managed as an outpatient. Sometimes the pain is so severe, but still it is not an emergency. You can manage it as an outpatient. Next. So this is a slide about meningitis. Meningitis is an infection of the brain. Meninges are coverings of the brain. You have, as we just talked about, we have 3 meninges surrounding the brain and spinal cord. And if they're infected, often with bacteria, it is called meningitis. And the 3 cardinal symptoms of meningitis: headache. So headache, fever, and rash. Rash may not be seen in a lot of cases of meningitis, but headache is very common and fever is very common. Patients may also experience neck stiffness. The traditional teaching is meningitis causes neck stiffness. Not all the times. Patients may or may not have neck stiffness. And patients, especially if they're immunosuppressed, may not have fever. And headache may be the only symptom with some confusion. So headache plus confusion can be the symptom of meningitis. So it all depends on what is your underlying premorbid condition. If you are on certain immunosuppressive medications like steroids or some medications for autoimmune diseases like methotrexate or such medications, you may not get a fever response because it is suppressed by those medications. So you may only get headache and confusion, and that can be a meningitis. And if you have rash, it points to meningococcal meningitis, and it is an emergency. The antibiotics have to be initiated very early on because, again, here patients can die with seizures and with herniation, and the infection can spread, causing sepsis within few hours. So meningitis is a neurological medical emergency. So if you have headache with altered mental status, right away, go to ER. Don't call your PCP or neurologist and wait for the response. This is a giant cell arteritis, also referred to as a temporal arteritis. Again, it can be chronic, but it can also cause acute complications. It is often a disease of elderly and often seen in women more than men. Common symptoms are headaches. They get fever, they get some jaw pain, they get some fatigue and some joint pains. So essentially it may look like a flu, and patients often may think it's a flu. and may start treating with some over-the-counter medications. And you can see on the right side of this picture here, the temporal artery is swollen, and it's very prominent. And it is so swollen that if you put your finger there, you may not even feel the pulse, because the blood flow is so very little, because it's so swollen. The blood vessel is swollen, and it may clot. And so the giant cell arteritis, if it is flared up, and it can lead to loss of vision, permanent blindness, and it can lead to stroke, because the same pathology that is happening in the temporal artery, which is shown here, is also happening in your brain, in your eye. So the same process. So if it obstructs your eye artery, you may become blind. If it obstructs your blood vessel in the brain, you may get stroke. The cause here is not a blood clot. The cause here is a swollen blood vessel that obstructs the blood flow. The treatment is very simple: high dose steroids. Here very important. Often patients neglect. I have seen cases where patients became blind and they ended up with ophthalmologist and came to neurologist later on to be diagnosed as a giant cell arteritis. So, and very simple to diagnose: simple blood test, high index of suspicion, simple blood test showing elevated inflammatory markers, high dose steroids, and you can avoid an emergency. So the important thing is keeping in mind that if you have a cluster of these symptoms, temporal headache, some blurry vision, and some flu-like symptoms, you need to consult your PCP or go to ER right away. Next. So seizures. Often people use different terminology in different areas. In Bharat, which is India, often people refer to seizures as fits, and there is a lot of stigma attached to it. I have seen during my childhood people falling on the streets and roads. They used to put coins, metal coins, saying it's a curse of a god, saying God is doing something to them. That's why they're shaking in their body. And of course, there's very, very minimal awareness in the community. A lot of people are aware of heart attack and even atrial fibrillation. They know about tachycardia, bradycardia, and there is not much awareness about seizures in the community. So high index of suspicion about seizures is important, because not all seizures are convulsions. Majority of seizures we see doesn't cause any convulsions, in fact. They just cause people to pass out. They're driving, and all of a sudden they ended up in a major accident because they they lost consciousness behind the wheel, or they felt suddenly they became confused behind the wheel, and they ended up hitting a pole or some cars. I have seen a case where this patient was, his parents came from Bharat, and he was taking them for a trip somewhere in near Aspen. It's a major highway he was going, and the next thing he remembers is it's a multi-vehicle crash, and he was the cause of it. And he went to his primary care and diagnosed as sleep apnea. And he came with his wife for a simple headache. And he said, "By the way, doc, I'm here with my wife. I just wanted to ask you, is it any of concern? I was driving like this. I passed out, and they told me I have sleep apnea. I feel good now." First thing I asked was, "This guy is so lean." I said, "There is no way you can have sleep apnea. You are so lean. Your neck is you have tall neck. You are lean, and very unlikely you have sleep apnea, at least clinically. So I will be surprised if you have sleep apnea. Even if you have one, I don't think that might be the cause." So we ended up doing MRI. He has a big brain tumor that causes the seizure, and he could not believe me when I called him on Saturdays. "Hey, I want to talk to you." He said, "Doc, you guys always call me on Sunday or Saturday." I said, "We need to talk." So he came, and he went and called back and said, "I think, are you really telling me the truth?" So because he could not believe it, that all of a sudden we found this big tumor that is caused by the seizures. So sometimes these things can be very subtle. So high index of suspicion is very important. So often patients can suddenly experience change in behavior. They are talking normally, all of a sudden they are staring into space. They are often called as absence seizures, often seen in children. And often, they may be told you have attention deficit or something like that. But they could be absent seizures. Unusual sense of smell or sudden emotional changes. They have sudden, like as if there is a switch. They have sudden change in behavior, and then a few seconds later, they're back. And that is a seizure. A seizure is an intense electrical discharge in the brain. It is a hypersynchronized electrical discharge in the brain. That's the meaning of it. The symptoms depend on where the seizure is happening. And a simple way to understand it is abnormal brain rhythm, like abnormal heart rhythm, it is abnormal brain rhythm. Symptoms can be any, depending on where the seizure is happening. So very important to think that anything that is abrupt in onset can be a seizure, especially if it starts abruptly, ends abruptly, lasts a few seconds to a few minutes, and no alternative explanation. Next. And if there is a seizure, especially convulsive seizure, because they can kill people, a seizure can intense electrical discharge, especially grand mal seizure, can send a lot of electrical current down your spine, and it can tase your heart, and your heart can stop. It may go into asystole, and the patients can die in sleep. And that is called a sudden unexpected death in epilepsy, especially a poorly controlled epilepsy. People die in sleep. And some in the olden days, they were diagnosed as sudden cardiac death. Some of these ones we are realizing these are epileptic in nature. So a seizure can tase any organ. Now we have what we call as a EKG changes due to neurological causes. People who have strokes and seizures are experiencing EKG changes. And even the heart can become like a congestive heart failure. The heart can become very big and may not work for hours and days, and may end up in congestive heart failure just because of seizure. And it is a brain and heart communication. So if somebody is having a convulsive seizure, convulsive seizure, make sure you put them on the side, not on the back, on the side. Do not put anything in the mouth, especially never put your fingers, because the jaw muscles can tighten so much, you can get really injured. So if you have anything, you can put a rolled towel in the mouth to prevent any tongue bite, and make sure things are clear around them, no sharp objects, and likely they should be on the floor, not in a chair, so that they don't fall and injure. And most important, observe, and if you have opportunity, record it on a cell phone or any camera, because that information is very useful for us to treat the patient. If you can record it, it is very useful. And of course, if seizure lasts more than 5 minutes, you should call 911, because it is a life-threatening emergency. Next. So this is a spinal cord compression from a bleed, and the left one shows a non-hemorrhagic spinal cord injury. So the patient may be traveling in a car, and then suddenly somebody braked in front of them, and you have a whiplash. Your neck went forwards and came backwards like a ping pong, and you have a contusion in the spinal cord and on the left side, and your vertebral disc has herniated there as well. On the right side, there is a hemorrhage inside the spinal cord. Both have significant bad prognosis depending on the level, especially if it is cervical. It can lead to quadriparesis. All 4 extremities can be paralyzed. So again, this is an emergency. So if a person has a whiplash-like injury, neck pain, and weakness in the arms or legs, or any change in strength in the legs, they should right away go to ER. Next. Okay, so this is some of my pictures of my yoga training. So I just want to show myself in different yoga postures, which I am happy to do now, which I could not do before.
Excellent.
Now open to questions. Binaji, yeah, go ahead. Binaji, we could not hear you. I think you are muted.
Oh, sorry. I'm saying we have, thank you very much, Doctor. We had so many questions on our chat, YouTube videos. So let me go at, Prasad, can you mute, please? Okay, we can start with, what is Prabhakar Kalkoti ji is asking, what is a cure for epilepsy?
So I would probably say epilepsy is treatable, very rarely curable. I would not say incurable, because the cause of epilepsy, one thing the training in Bharat cherishes is we are always told to look for the cause, not just treat the symptom. Epilepsy, when you say epilepsy, the first question I'll ask is, what is the cause? Is it a tumor related? Is it a meningitis related? What is the cause that triggered epilepsy? Is it genetics that triggered it? Essentially, the cure depends on the cause, and some of the causes are not removable, so there is not curable, but treatable with medications. Let us say a person has a bleed that causes seizure. Yes, you can remove the bleed and cure. If the person has a tumor, you can remove the tumor and the patient can be potentially cured. But if it's a genetics involved, like channelopathies, channel problems, sodium channel, potassium channel problems, the possibility of cure is less. Children often can get cured spontaneously, because a lot of times in children, it is genetics, channelopathies play a role. In adults, it is often scar tissue that triggers. So often we don't go and remove the scar tissue in every patient because it is not fruitful. And a lot of times we don't find a scar tissue because it's so small. And the EEG may be abnormal, but if person has a repeated seizures, yes, we do what we refer to as a in-hospital EEG monitoring to localize where the seizure is coming, and then take that piece of the brain surgically, remove it. And then that potentially could be a cure. Particularly, there is something called temporal lobe epilepsy that comes from temples on sides. And here the patients can have very weird symptoms. And there is one doctor in University of Southern California, I believe that's a university. He documented a lot of cases where patients were labeled as, oh, you are possessed by devils, you are possessed by this. Because this patient was, suddenly he becomes abnormal and he professes some kind of prophecy. And the family was very stressed out. So he did a lot of fMRI studies and all those, and he localized that this is in fact epilepsy. So, and he essentially was cured by surgical treatment. If there is a scar tissue, good enough, they can remove it and it's a cure. So yes, very weird varieties of symptoms, not just convulsions. So that's why index of suspicion is very important. Cure depends on the cause. That's the only way I can say it.
Okay, thank you. Now we go to a question from Rajuji. His question is how to prevent the formation of arteriovenous fistula in the brain. What precautions a patient can take who already had brain fistula surgery once?
So often these fistulas are congenital. That means they're born with it. Sometimes these fistulas, like aneurysms, may be small. And when you do angiograms, you may not see them. But with time, they become bigger and you can see them. So it may be recurrence at the same place or may reappearance at a different place because that was small before and now it became big and visible. Sometimes traumas can cause fistulas as well, but it is not like cured with medicines because it is a structural problem. Often it ends up needing surgeries. And a lot of times it can be genetics involved. It can run in families. So so sometimes it's unfortunate that these patients get repeated AV fistulas, arteriovenous fistulas and aneurysms. So we always scan them again and again. Like even if they are treated, we scan them every few years with angiograms to see if a new aneurysm or fistula is happening. And when they become significant enough, we send them for intervention to close it surgically or by intervention with catheters.
Okay, thank you. Now the next question is by Poonamji Simlote. How long is there a risk for stroke after TIA?
Oh, TIA refers to transient ischemic attack, which is like angina to the heart, and a stroke is like a heart attack. So if somebody has a TIA, that means a blood vessel is blocked for a certain period of time, but somehow spontaneously the blood vessel opened. So whether spontaneously, because our blood has clot dissolving factors inbuilt into it. So sometimes they open the blood vessel spontaneously. and patient gets a stroke-like symptom, and within 5-10 minutes they're back to normal. So the symptoms are resolved. So, but don't celebrate, because that is an opportunity to treat. Because once you have a TIA, that means a clot is coming from somewhere. That means we have time to go ahead and aggressively treat to prevent a impending stroke. A TIA is a warning sign that a stroke might be coming. So if you have TIA, get it evaluated and right away treat it to prevent a massive stroke. Studies have shown that once a person has TIA, they have a significant risk of stroke in the next 3 months. I don't have the exact numbers here, but the risk is significant. That's why we put them on aspirin. If they have irregular heartbeat, we put them on like warfarin or Eliquis-like medications. So the important thing is evaluation. So TIA means you are given a second chance. Don't lose that chance to prevent a stroke.
Okay, thank you. Thank you. Someone has asked, Urmishri Rautre. She has asked, my son has gone for DBS surgery for refractory epilepsy. After DBS, he's not able to stand upright. What treatment we should do now?
So, so it's a very complicated question. DBS stands for deep brain stimulation. There are various neurostimulatory devices now to treat neurological disorders. Vagal nerve stimulator is there, deep brain stimulator is there, responsive neurostimulator is there. So varieties of neurostimulations. My suspicion is in that case, there was some post-operative or intraoperative complication, because generally, at least as far as I'm aware, these are pretty safe surgeries, but somehow I think in sometimes there can be a bleed or some complication, and it may catch some fibers going to the legs, and they may get paralyzed. So depending on how it happened and when it happened and why it happened, the treatment will vary. Like maybe aggressive physical therapy, and if the injury is irreversible, the electrode may not be changed or pulled back, then it may only need a lot of physical therapy and may not improve. We have to admit that.
Okay, thank you. Now, I think this is a very, very common question asked by Kiran Bala Sahuji. I think it's most of us have that. Hi, sir. What is the remedy for migraine headaches? So, can you give us the permanent solution? So, if there is any.
So I think I will use yogic methods also. I'll describe some natural yogic plus allopathic. So because a lot of times now I am seeing patients who come to me and say, hey, I came here. Can you tell me something natural? I don't want pills. I don't want prescription. Just give me something natural. One thing that has been tested is magnesium sulfate. Because what we are finding is a lot of migraine patients have low magnesium in spinal fluid. So magnesium sulfate around 500 milligrams to 1000 milligrams helps. And I have seen lots of patients who tested it, and actually they came back and said, wow, it helped me. Second, vitamin B2, not B12, it's B2. It's called riboflavin. It also helps around 250, 300 milligrams range. It does help as well. Obviously, not much side effects with any of them. Sometimes magnesium may cause diarrhea, so you have to just test it and see. Varieties of magnesium are there: magnesium sulfate, citrate, oxide. So you can test like sulfate first. If it doesn't work, you can go to gluconate or oxide, magnesium oxide. You can test them. So those two at least were tested, and some good data is there. There is another plant extract. It's called butterbur. It has nothing to do with the dairy product. It is a plant extract. It's called butterbur. It does help with migraine headaches as well. Some I have seen at least one study or so where it did as good as a Topamax, which is one of the prescription medication. So those three I would probably recommend to patients if they want some natural therapies. And a lot of pranayams help. So obviously there are not many studies. But personally, how the migraine starts, how it progresses, I can say if you do Kapalbhati example, it may help. It's worth trying, harmless, and you can do it every day. So worth doing it. There are other yogasanas that are also there, but most of these natural treatments take time. You have to have trust, and they take time. If you just want instant gratification, yes, you'll get pills, prescription pills. They will help you, but not a good long-term strategy. So if you want some long-term relief, combine some prescription medications for a short-term treatment, and then at the same time start some natural supplements, maybe some yoga plus pranayams.
Okay, thank you. Now someone, Gopal Vyasji has asked, how Bell's palsy can be treated?
So I think we have one of the picture there during our presentation. Bell's palsy is a diagnosis we give when no other cause for facial paralysis is found, and it is a full facial paralysis. That means entire nerve is involved. Upper face and lower face, both are involved. And if no other cause is involved, MRI shows nothing, then we presume it is Bell's palsy. It is due to herpes virus reactivation. And often these patients have some ear pain, some change in taste on the tongue when they get acute Bell's palsy. Most of the patients with Bell's palsy recover spontaneously. They get steroids, they get some antivirals, and they recover. But sometimes the recovery is incomplete. And those patients will need some physical therapy, electrical stimulation, and there are some testing you can do to prognosticate, especially how much is the nerve injury. You can do like EMG, a facial nerve, to prognosticate what is the extent of the injury. If somebody has not recovered by, I would say 3-6 months, the chance of full recovery becomes slim. Most of the patients recover within few days to few weeks, 80% or so recovery. So around 10 to 20% of recovery may take, few months. But majority of the patients will be recovered by 6 months. If you don't recover by then, you may be left with a residual injury, and it may be too late to do anything more at that time. Physical therapy may still be done, and you may attempt to do some physical therapy and electrical stimulation of the facial nerve. But again, the chances of recovery may be limited.
Thank you. Someone has asked a question about what is the, I forgot, okay. Why do we lose memory and hearing loss? Is there something neurological effect, or is it just the age, or what causes that?
So memory is a very broad question, and it is not a emergency. If somebody loses memory in emergency, there might be something going on, like seizure might be going on. People have seizure and may have transient memory loss. But if it is a chronic memory loss, yes, there are lots of syndromes like dementias, nutritional, neurodegenerative, even depression can cause it, Alzheimer's, varieties of cause. So it is a very broad symptom. It needs extensive evaluation because it's a very chronic condition. But if somebody has acute episodic memory lapses, could be seizures. And I have personally seen patients who are told that you're having Alzheimer's disease on and off. And it doesn't come and go. Alzheimer's or dementia doesn't come and go. It stays. So if somebody has this lapses of memory, a few seconds, few minutes, it could be seizures. Particularly, EEG may help, MRI may help in diagnosing. So I think there was another question tied to it, right? Some ringing in the ears, somebody said?
Yeah, hearing loss.
Hearing loss, yeah. So hearing loss, again, can a lot of times it is not a emergency because it never presents alone. If somebody has a dizziness plus hearing loss, it's a brainstem stroke or cerebral stroke in that area, posterior circulation. Hearing loss alone, rare. At least personally, I have not seen. There might be some case reports where a stroke happened and patient has a unilateral hearing loss. There are some tumors which can cause a hearing loss, one-sided hearing loss. These are called cerebellopontine angle tumors. MRI may help, but they're generally chronic. They can be episodic, comes and goes, but they're chronic. If somebody has acute hearing loss, this could be a rare type of stroke, probably a reportable case of stroke.
Okay, thank you. I think we'll only take one more question because it's 9:05, and then okay. someone has asked, what about the artery or the vein that is vein on the forehead straight down? Does it have any, what is that called?
So I'm suspecting they might be talking about some stain, like a blood vessel dilatation. These are often congenital, like port wine stain and are different, these are all congenital variations. Sometimes give an idea what might be going on in the brain, like tuberous sclerosis, which is a condition where patient can have seizures and they have what we call cutaneous manifestations. So if you see the skin manifestation, you can predict what might be going on inside the brain. So those are called neurocutaneous syndromes. Neurofibromatosis is another neurocutaneous syndrome. So I think I'm suspecting they might be referring to port wine stain. Sometimes they call as a kiss of an angel, so these are all indicative of something might be going on inside. That certainly needs to be evaluated if they have any neurological symptom other than just cosmetics.
Okay, thank you so much. We have so many questions, Dr. Sunil ji, and some people need your contact information, so I think we'll share offline with them. I just want to thank everyone, Dr. Khandelwal ji, Dr. Sunil.
Thank you, Sunil ji. That was a really wonderful talk.
Yes.
And I think, all thanks to Dr. Khandelwal ji for organizing these fantastic events for the community. Obviously, I have done this, I think, a couple of years ago on migraine. There was excellent feedback at that time as well. I hope we continue to do that.
Thank you. Thank you. I really enjoyed it.
Thank you. Thank you. Before we go, I just want to, say JKYog Academy offers so many free online sessions. And today we have started receiving mind management challenge videos. And Swamiji has given us 21 days of tools to improve our, our life. And so those videos are going to be published on Fridays, Mondays, and Wednesdays. So it's going to last till October 28th. So do take advantage of that and register on www.jkyog.org/mmc for Mind Management Challenge. Okay, so thank you all for a very good session. Thank you, Dr. Sunil ji and Dr. Khandelwal ji. Thank you. Radhe Radhe.
Thank you.
Radhe Radhe. Dhanyawad.
Radhe Radhe.
Radhe Radhe.
That was really great talk. Great talk.
I forgot.